Hello students, welcome to today's session. Here we are going to talk about WHO Labour Care Guide. So this is the next generation partograph. So in this session we are going to talk about the partograph and what are the improvements or the newer partograph, the next generation partograph, the WHO Labour Care Guide it is called. Partograph is a graphical record of the observations made in a woman during labor. So as you all know, it is a graphical representation. This is how you define partograph. So whenever you start about WHO Labour Care Guide or partograph, this is what you should begin with. It is a graphical record of observations made in a patient or a woman who is in labor. The progress of labor and the condition of mother and fetus, everything is recorded in a single sheet of paper. It is developed and tested by WHO. So coming to the history of partograph, here you should know a bit of history on partogram, how it was initially given and what are the modifications done as of today. So initially Friedman gave us in 1954 a curve called sigmoid curve or a S-shaped curve. When cervical dilatation was marked against the time, it gave us a S-shaped or a sigmoid curve, and when head station was marked, it gave us a hyperbolic curve. Philpott and Castle in 1972 gave us the alert and action line. The concept of alert and action line. Drawn a slope at 1 centimeters per hour. You can see in this line, this is the alert line. This is the 4 hours apart. So this is the alert line and this is the action line. This concept was given in 1972. So this was what we were following till date. Now coming to the next generation partograph or the WHO Labour Care Guide. The main aim or this tool is mainly used to implement recommendations on intrapartum care for a positive childbirth experience. Every woman undergoing labor should experience a positive care. This is the main aim of the new generation or the next generation partograph called WHO Labour Care Guide. That is, WHO recommends intrapartum care for positive childbirth experience, and WHO says this labour care guide as next generation partograph. Understood? So before going to the WHO Labour Care Guide, let us know what is this. In your Viva examination, you must be commonly asked, what is a paperless partograph? So this is the paperless partograph. Here you only write boldly on the case sheet, in the front page of the case sheet, the alert expected time of delivery, this one, and action expected time of delivery. This is based on the Friedman's commonly accepted rule, that is, in active stage of labor, cervix dilates at 1 centimeter per hour. Imagine at 4 o'clock a patient is 4 centimeters dilated. So 1 centimeter per hour she should dilate from there to become 10 centimeters, that is 6 hours. So to add 6 hours to 4 o'clock it becomes 10. So by 10 o'clock she should deliver. Once she enters the active stage of labor, by 6 hours the alert line ends. So this gives us the alert expected time of delivery. So in this patient by 8 p.m. she should deliver, and the action expected time of delivery is adding 4 hours. You can give an extra of 4 hours and not more than that. So by adding 4 hours you will get 12 midnight. So this patient should deliver by 8 p.m. as expected, and you should act by then if she is not delivered, and if still she is not delivered by 12 midnight, you should definitely take a action there. Now coming to the WHO Labour Care Guide, the aim of the guideline is to improve the quality of essential intrapartum care. The quality of intrapartum care with ultimate goal of improving the maternal, fetal and newborn outcomes. So these are the things that we are going to discuss in detail: how respectful labor and childbirth care should be, emotional support, effective communication by staff, pain relief strategies and how do you explain to the patient, regular labor monitoring and documentation of the same, oral fluid intake should be allowed to the patient, mobility in labor is good, pre-establishment of referral plan. For example, you should be monitoring her and then how you will explain the further progression of labor, or if doesn't progress, what is the referral that should be explained to the patient in detail. and continuity of care throughout the labor. So this is all what the new labor care guide or the next generation pathograph has. So let us talk it in detail. Why do you want to follow this labor care guide? To improve every woman's experience in a childbirth. So this is the main aim, to give a positive experience for a childbirth for every woman. Health and well-being of both women and the baby. Good quality and evidence-based clinical care in all settings. Expands the focus of labor monitoring to non-clinical practices that improves the positive childbirth experience of every woman in labor. So, for example, the non-clinical practices like allow a companion to stay with her, give her the moral support or explain her the progress of labor. These are the non-clinical practices that gives the mother a positive childbirth experience. The new labor care guide is initiated when the woman enters the active phase of first stage of labor, that is at 5 centimeters. Previously we used to document from 4 centimeters. Now it is changed to 5 centimeters or more of cervical dilatation. Regardless of her parity and membrane status, from 5 centimeters we start plotting the labor care guide. Although labor care guide should not be initiated during the latent phase of labor, it is expected that women and their babies is monitored and they receive a labor care support during latent phase also. Though you start the monitoring chart only in active phase of first stage, even in the latent phase also you should be monitoring her. Where should the labor care guide be used? It is designed to use all levels of care, healthcare facilities, although the plan of action will vary depending on the level of care. For example, if she is in a tertiary care center, if there is any problem in the fetal heart rate or the contraction or she is not delivered on time, the immediate action can be taken. Whereas if she is in a primary health center where the facility for cesarean is not there, then plan for referral should be started early. So the plan of action depends on the level of health care that she is on, but definitely it should be followed in all the hospitals or all level cares of health facilities. The use of labor care guide can facilitate early identification of potential complications and hence contribute to timely referral when required. So the potential to identify complications early is one of the important thing why we should do these labor monitoring or follow the labor care guide. So the structure, this is how the labor care guide looks. The new labor care guide looks like this and it has 7 sections. Okay, the section 1 is the identification of patient, 2 is supportive care, 3 is care of the baby, 4 is care of the women, 5 is labor progress, medications, and last comes to shared decision making. So these are the sections of the new WHO labor care guide. In detail, let us see what is individual section. So let us begin with first section. The section 1 is identifying information, for example, name of the patient and parity of the patient, and labor characteristics at admission. At admission, what is her labor stage? For example, in this labor onset, whether it is spontaneous or induced labor. Active labor, when did she start? Date and time of active labor. And ruptured membranes, whether the membranes are ruptured after entering into active labor or in latent labor, or she had premature rupture of membranes. And what are the other risk factors associated like hypertension, GDM, anemia? What are the other risk factors associated with this? So these are the basic details that you will enter for a patient in section 1. It is just like a history. Coming to the supportive care, it aims to encourage provision and monitoring of supportive care, like it includes labor companionship, whether the patient has a companion or no. It is denoted as N for no companion, yes for a companion is there, and D if the patient declines to have any companion. So this is how you write. If the patient has a companion along with her, you should write it as Y, yes, she has a companion. N denotes no companion. And D denotes that she declines a companion. She doesn't want. Pain relief. Pharmacological and non-pharmacological methods of pain relief. It is highly encouraged in labor. If she is given a painkiller, then you write it as yes, and you can mention the drug, whatever you have given, like epidural, tramadol, whatever is the medication that you have given, whether pharmacological or non-pharmacological, you should mention, and if you have not given, it is denoted as N. Oral fluid, whether you allow her oral fluid, yes or no, okay. It is highly encouraged to give her oral fluid and maintain hydration. Posture, to improve the women's comfort, you always ask her to mobilize, and as we all know, the more they walk, faster is the delivery. Posture, whether it is supine posture or mobile. SP denotes for a supine posture and M denotes for a mobile, that she is actively mobile during her first stage of labor. If she is not able to move, then she can be supine, definitely. But if she has the energy to go around or move during labor, walk, then you should always encourage her to walk. So finally, in section 2 has companion, pain relief, both pharmacological and non-pharmacological, and oral fluids, whether you are allowing her orally or no, and then posture of the patient, whether supine posture or she is mobile. Coming to section 3, care of the baby. Now you have given a supportive care to the mother. Now this is designed to facilitate decision making while monitoring well-being of the baby. So all the monitoring that you are doing for both mother and the fetus, yes or no? So the mother's health is equally important as baby. So how do you monitor baby's health care or the care of the baby? Baseline fetal heart rate. What is the baseline fetal heart rate? So the baseline fetal heart rate is here 110 to 160 beats per minute. It's all mentioned here in the alert column. So you should be knowing this. If it should be more than 110 and less than 160 to say it as normal. For example, if the heart rate is 134, you will write it as 134. If it is 140, you write it as 140. And if there are associated decelerations, what are the different types of decelerations that you know? Early deceleration, late deceleration, prolonged deceleration or variable deceleration. So you can write it here. If there are deceleration, late, yes, late deceleration, variable deceleration, prolonged deceleration or early deceleration. Early deceleration is physiological and normal in second stage of labor. So these are the different types of deceleration. What are the deceleration, baseline heart rate, what is acceleration is detailedly explained in your CTG class and NST class. You can go through that video once for your knowledge on deceleration and how do you monitor the fetal heart rate. Next, coming to amniotic fluid. So this is how you mention. If the membranes are intact, it is not ruptured, then you write it as I, okay. Amniotic fluid. So how do you monitor amniotic fluid? If the membranes are intact, you will write it as I. If it is ruptured and clear liquor, you write it as C, and then if it is having meconium stained liquor, you write it as M. If it is blood stained liquor, you write it as B, and if it is absent liquor or no liquor, you write it as A. So this is how you mention about your amniotic fluid. You write it here, intact or amniotic fluid is clear and amniotic fluid is meconium stained, blood stained or absent. So this is how you write it. Next, coming to fetal position. Fetal position is the relationship of the presenting part to that of the quadrants of the pelvis. So if it is an occiput, if it is occipito anterior, you write it as A. If it is occipito transverse, you write it as T. If it is occipito posterior, you write it as P, because the position of the fetus plays a main role in normal labor or mechanism of labor, as we all learned this in normal labor session. So coming to the caput and moulding, let me show you how do you assess moulding and grade it. So increasing moulding with head high. If the moulding is increasing and head is still high in the pelvis, it is an ominous sign that there is a cephalopelvic disproportion. So it is one of the good sign or early identifying sign for cephalopelvic disproportion. If the bones or the suture lines are separated, then you say it as no moulding. You can feel the suture lines easily, then it is no moulding. Bones just touch each other, then it is +1. If the bones overlap but can be easily separated, then it is +2. So the severely overlapping suture lines As in here, if they are severely overlapping and cannot be separated easily, it is grade 3 molding or +3 molding, and it is a sign of cephalopelvic disproportion where the head has some obstruction to get descended down into the pelvis. So, to brief the section 3, the care of baby, you will monitor the baseline fetal heart rate, you will monitor the decelerations, you will monitor for the amniotic membrane, and if it is ruptured, like a color, and you will monitor for the fetal position, whether it is occipito-anterior, transverse or posterior. Then you look for caput and molding. Section 4, coming to the care of the women, you should be monitoring her pulse, blood pressure, temperature and urine output. What is the normal range of pulse? 60 to 120. In a previous LSES, when you are trying for trial of labor after cesarean or trying for a vaginal delivery, if the pulse rate is high, then it's a sign of uterine rupture. Okay, so you should monitor her pulse very carefully, especially in a post cesarean case. Coming to blood pressure, the systolic blood pressure should not be less than 80 or more than 140, and diastolic should not be more than 90 mm of Hg. Coming to temperature, it should range between 35 to 37.5 degrees Celsius. So, why do we monitor temperature? If she is having a history of leaking PV for more than 24 hours, she has more chance of developing chorioamnionitis. So, you should check for her temperature. She should be afebrile and not develop infections. Urine output, especially in hypertensive patients, you should check for protein in urine and acetone in urine. If it is there, it is labeled accordingly +1 or +2 as it is seen. So, this is how you monitor the mother. You will check for her blood pressure, you will check for her pulse, you will check for her urine output and you will check for her temperature. Coming to the section 5 of labor care guide, that is labor progress. Now, you have taken the initial details of the baby, given her a supportive care, checked for the baby, checked for the mother. Now, coming to the 5th and the main important section, the labor progress. Aims to encourage systematic practice of intermittent monitoring of labor progress parameters like frequency and duration of contractions, cervical dilatation and descent of the baby's head. So, here you can see this is the dilatation 5, 6, 7, 8 centimeters. So, this is the dilatation and this is the alert line. This is the new modification. Please go through this carefully. So, this is the new modification. For example, in this patient, as you all know, we start labor care guide from 5 centimeters. So, if a patient comes to you at 5 centimeters and you write down here as 5 centimeters against the timeline, at whatever time she has come, that is her 5 centimeters. From there, you can wait for 6 hours, and if there is no progress for 6 hours, it is here 6 hours and there is no progress for 6 hours, then you should start your action. Usually, cervical dilatation is checked every 4th hourly in active stage of labor unless otherwise indicated. For example, if she has leaking PV, then to see if there is a cord prolapse or no, you might check in between. But usually it is checked every 4th hourly. If you are doing any time in between, make sure you take more extra details that will help you to assess the labor and change your plan of action. The same thing you can see, if she is 6 centimeters dilated, not more than 5 hours you should wait, and if she is 9 centimeters dilated, in next 2 hours she should deliver. So, the alert time is given there only in the chart. This is how you plot for cervical dilatation. It used to be plotted as X, okay, you can write it as X. For example, if she is 7 centimeters dilated, you will write it as X against the time. At imagine 12 am, she is 7 centimeters dilated. So, in next 3 hours, she should be delivering. How do you monitor the contractions? Previously, this is how we used to monitor contractions every hour in the latent stage and in every half hourly in active phase of labor. So, here you can see every 30 minutes. So, this is a duration of 1 hour. Every 30 minutes we monitor contractions. It is divided into 2. 1 hour is divided into 2. So, every 30 minutes we monitor contraction in active phase of first stage of labor, whereas in second stage of labor we monitor it every 15 minutes. So in latent phase you will monitor every hourly, in active phase you monitor every 30 minutes, and in second stage of labor you will monitor every 15 minutes. This is how you monitor for your FHS or even for your contractions. How do you check for contractions? See, frequency of contraction and duration of contraction. It is like this. In 10 minutes, you check for contraction. In 10 minutes, how many contractions she had? Like she had 3 contractions, 2 contractions, 4 contractions. And what is the duration of each contraction? Like she had 1 contraction lasting for 20 seconds or 1 contraction lasting for 30 seconds. This is how you write. Previously, we used to mark it like this. Less than 20 seconds, we used to dot it, and more 20 to 40 seconds, it used to marked as lines, and in more than 40 seconds, it was blocked. Presently, we write it like this. Every half an hourly, you are monitoring in active phase of first stage of labor. So, for example, initially she had 3 contractions and lasting 20 seconds. Later she had 4 contractions lasting 60 seconds. So, the normal contraction should be more than 20 seconds and less than 60 seconds. And number of contractions should be more than 2 and less than 5. Otherwise, baby can have fetal distress causing tachysystole or hypercontractions. So, this is how you monitor the contractions. How many contractions and lasting how long? In every 10 minutes. For a 10 minutes, you will check this and you will monitor. In active phase, you will monitor every half an hourly. In second stage, you will monitor every 15 minutes. Coming to the descent of the baby, you will write it as O or plot it as O. So, as we already discussed, the cervical dilatation, you will look for the dilatation and you will start from 5 centimeters of dilatation, the labor care guide, and note the time below and vertical line marked as X. We showed it here to you. You will mark it as X. For example, at 12 o'clock, she was 7 centimeters dilated, and in next 3 hours, she should deliver. This is how you mark. Now, to brief about the labor progress, what are the things that you assess to know the labor progress? Firstly, on examination of per abdomen, you will check for the uterine contractions, how many in number and lasting how long, what is the frequency and what is the duration of contraction. Secondly, you will check for the cervical dilatation, what is the dilatation. So, from 5 centimeters, you will start your labor care guide, and along with that, there is an alert line like 5 centimeters, she should deliver in next 6 hours, or there should be progression in next 6 hours, and if she is 7 centimeters, in next 3 hours, there should be progress, or if she is 9 centimeters, in next 2 hours, there should be progress. So, this is the cervical dilatation you will check, and then finally, you will check for the descent of the baby or the station of the baby, and you will plot it as O. What is the station of the baby? Coming to section 6, medication. It aims to facilitate consistent recording of all type of medicines used in labor, like oxytocin and its dose. Here you can see the column oxytocin and its dose, like 6 drops per minute or 12 drops per minute based on the contractions. If the contractions are adequate, you can stop the titrating dose of oxytocin, or you can titrate the dose of oxytocin as and when required. And also other medications that are used. For example, if you have used a pain relief medication, what is the medication? Tramadol. Or what is the medication for cervical effacement improvement like Drotin, Epidocin. If you have given any other medicine, you can write it down. And IV fluids, whether she is allowed orally or you are giving IV fluids, you can mention yes or no, or if yes, what is the IV fluid, like normal saline, DNS, what is the IV fluid that you have been giving. So, this is the medication. You will write about oxytocin, other medicines that you are giving, and also IV fluids. All these things are mentioned in this section 6. Coming to the last and final section, section 7, shared decision making. So, till now whatever you read was already there in the partogram. It has been modified or added on new things. But yes, this shared decision making is the new thing that is added in the WHO labor care guide. It aims to facilitate continuous communication between the women and her companion. You should always tell her assessment to her and consistent recording of all the assessments and plans agreed. whatever pain relief, whether it is agreed, companion, whether it is agreed or no, those things has to be explained in detail and written it down on the WHO Labour Care Guide. Clear explanation of the procedures and their purpose should always be provided to each woman. WHO recommends effective communication between maternity health providers and women in labor, including the use of simple, culturally appropriate language. So, whatever language is that she understands or it is locally acceptable, with that you should be able to explain her in detail. So, that is the main aim. WHO recommends communication between the patient and the doctor. For example, assessment, whether you have assessed required for pain relief or normal progress is there, that is what you will write here, assessment. There is clear liquor, membranes ruptured, pain relief required, normal progress is there, that is how you assess. And plan of action, monitor, normal progression is there, monitor, or if referral required, referral in view of. This is what you have to write in your WHO Labour Care Guide of section 7, the final section. And finally, there is a column of initials. So, you should be signing after writing everything, okay. So, after writing everything, you have signed. So, finally, what are all the things that we have? Section 1 to 7. So, section 1 to 7, these are the things. Firstly, identifying the patient and labor characteristics, like name of the patient to onset of labor and rupture of membranes. This is what you write in your first section. Coming to the second section, the supportive care, where you will tell the patient about the pain relief, you will allow a companion to stay with her, you will give her oral fluids, and you will ask the patient to be mobile or supine if it is pain is very high. And coming to the third section, care of the baby. Here you will monitor the fetal heart rate, baseline heart rate, deceleration if it is there, and you will check for the amniotic fluid, you will check for the caput and moulding. Coming to the care of the women, where you will check for the pulse, BP, urine output and temperature of the patient. Coming to labor progress, where you will check for the contractions. Per abdominally, you will check for the contractions, how adequate it is, whether number of contractions more than 2 and less than 5, and each contraction lasting more than 20 seconds and less than 60 seconds. And also you will check for cervical dilatation and descent of the fetal head. Coming to the sixth section, that is medication. What medications you give, for example, oxytocin, what is the drip rate that you are giving, how many drops per minute, what is the flow rate, is what you should write. And also other medications that you have given, like tramadol or drotin epidocin for effacement of the patient. These medications also has to be mentioned. If she is hypertensive, if you have given labetalol injection, these medications also should be mentioned. And also IV fluids, whether you have given her IV fluids to maintain her hydration. Coming to the last and final section, the shared decision making. As we already told, the shared decision making is for good communication between the doctor and the patient to tell her about the plan or progression of the labor. Now you learned everything about the labor care guide, what are the different sections and each section has what in it. So how do you put it into action? This is for a positive feedback and decision making loop. As healthcare professional, you should be knowing. Assess the patient, well-being of a woman and her baby and progression of labor. Record and document the labor progression. Check referral threshold. Compare the labor progression with reference values in the alert column that we have told you already. In cervical dilatation, all these things they have given it, that should last not more than so many hours. Or in contractions, how many contractions should be there and each contraction should last how many seconds. So you should check the alert column whether she is crossing that limit or no. Plan and decide whether and what intervention is required in consultation with the women and the document it accordingly. Your plan should be in coordination with the patient. You should tell the patient the labor is going slowly, we will add oxytocin, whatever you have planned, you should tell the patient and document it accordingly. So this is all about the WHO Labor Care Guide, the next generation partograph. So I hope I cleared all your doubts and you will be able to answer in your exams, practicals and MCQs. Thank you.